Welcome to Understanding Emergent Heart Conditions. You can find this on pages 114 and 115 of your Nurse Workbook 2.0. The whole purpose of this is to provide you with so much more information beyond the Nurse Workbook, but give you real-world nursing education as well. We've learned so much through this cardiac module, and I am so happy to talk about these final two emergent conditions that we see here in our Nurse Workbook 2.0. And the thing about these two conditions is that if you find yourself in triage or you already are in triage, you'll understand how these are two that can get a little tricky to spot, but they're very important to understand in order to help our patients emergently. So let's really learn what cardiogenic shock is. So this is going to be the inability of the heart to pump enough blood out to the rest of the body. So although there is plenty of blood present, our heart is not able to squeeze or provide enough cardiac output to perfuse the rest of the body and organs. So what causes this? Well, this can be a contraction issue. So our systolic, so when the ventricles are contracting, are they doing a good squeeze or a good enough job? This can also be a filling issue, so potentially on our diastolic. So when those ventricles are relaxing, is something going on that's preventing the blood from filling adequately? It could be from a dysrhythmia, and maybe this is structural, such as our blocks that are causing certain arrhythmias. And this could be common in heart attacks. And remember that heart attacks mean a lack of ischemia or lack of oxygen, which can do a whole bunch of things. It can make it structurally not well, but it can also affect the electrical system. So the symptoms of cardiogenic shock are going to be our tachypnea, and this could be acute or severe, so that difficulty breathing. So if we're not having good cardiac output because we're not having good squeeze, eventually we're going to start breathing faster because we're going to be looking for more oxygen to be coming in, more oxygen demand because it's not going around our body. This will also be shortness of breath, which goes hand in hand, tachypnea, and our sudden rapid heart rate and weak pulses. So our heart's beating faster because they're trying to compensate. It wants to try to deliver more and work harder to get better squeeze. But of course we have weak pulses because we don't have good cardiac output coming out our heart to the rest of our body. And we'll see a low blood pressure, sweating, and pale skin. And this is because, again, not a lot of output means not a lot of blood pressure. And so sweating and being pale are signs that we see when all this stuff is going on. And we're going to treat this by restoring really what the problem is. So whatever that cause may be, when we fix it, we should hopefully be out of our cardiogenic shock. We can also really utilize a balloon pump here that we already talked about to try to fix this issue. And it's important to remember that this is a situation that we do not want to give fluid because we don't want to create more volume if we're already having a pump problem. So if we're already having a hard time getting cardiac output out, if we just put more fluid in, we're essentially going to be drowning ourselves in fluid because we can't get what's already there around the body. Now we're going to move into our hypertensive urgency or emergency. So we have two patients that walk in the door, and both of these patients, can you believe it, have a blood pressure of 225 over 115. So one patient we see with this blood pressure, we look at them overall and we say, okay, they have really high blood pressure, but they have high blood pressure. I'm going to have you sit and I'll get you to a room as quickly as possible. The other patient comes in, they have that 225 over 115 blood pressure. And I'm looking at them and I'm doing some more questions. And suddenly it hits me that I need to get them back to the room as soon as possible. So what is the difference? Why is one of these an emergency and one of these is, yes, very important, but not so much of an emergency? So we have hypertension, and then we have hypertension emergency or urgency, depending on what you call it or what your facility calls it. So how are these different? Well, this is when blood pressure is very high, but it's capable of impairing one or more of the organ systems, such as the brain, eyes, heart, aorta, kidneys, and so forth. So that is our answer. So the first patient with the 225/115, well, this patient's had high blood pressure for years on end. They have no symptoms. They have no headaches. They don't have any dizziness, blurred vision. There's nothing going on. They said that they actually skipped their medications for a day or two. And so we know that this is a chronic situation. This is chronic hypertension. So our other patient that we got really nervous about, this patient not only has blood pressure of 225/115, but they've got headache, they've got blurred vision, they're feeling nauseous, and this means that this is acute. This is suddenly coming on. And so this we really need to fix because it's impairing something in this person's system. So once we get that blood pressure down, it will save the other organs. However, there's ways that we handle this kind of intervention. So the most important vital sign to monitor during a hypertensive emergency is our blood pressure. But it is most important to target our MAP instead of chasing our systolic and our diastolic numbers. So to avoid this, the blood pressure must be lowered in minutes to hours, and this is going to be using IV antihypertensive drugs. The goal of decreasing blood pressure should aim to decrease the MAP by 15 to 25% within 1 to 2 hours. And if tolerated, we can reduce the blood pressure by approximately 120 millimeters of mercury over 2 to 6 hours. So this is saying that we do not want to bring our friend that has a 225/115 blood pressure immediately down. We don't want to put them on this drip and watch them plummet. And there's multiple reasons why. So this is very, very important. So remember to test your knowledge about this again. If you see this come in, don't drop them quickly. And blood pressure lowered too fast can cause what 4 things and why? So first one, we can cause an ischemic stroke. And this is because the brain is sensitive to rapid changes in blood pressure. So if our blood pressure is lowered rapidly, it can decrease perfusion to the brain and lead to an ischemic stroke. We can also cause coronary ischemia. And this is because hypertensive emergency may already compromise our coronary blood flow. So a rapid reduction in blood pressure can actually reduce perfusion even more, and this will cause angina or even a myocardial infarction. So to recap, that means that high blood pressure might actually be causing some poor perfusion to those coronary arteries. So then if we go ahead and we open them up, they might actually lose even more perfusion, and this can give us that ischemia. We also can cause worsening kidney function. This is because the kidneys depend on a certain pressure gradient to filter our blood effectively. So a rapid blood pressure decrease can lead to a decline, especially in people with ongoing kidney disorders. And lastly, we can cause retinal damage. So rapid reduction in our blood pressure can exacerbate retinopathy, which is damage of the blood vessels. And this can lead to retinal hemorrhages as well. So remember to watch your maps, remember to go slow to avoid these complications. And this concludes our lesson, and I will see you in the next one.